and welcome to this presentation on pulmonary arterial hypertension, or PAH, and adult congenital heart disease, with a focus on PAH associated with systemic-to-pulmonary shunts. My name is Dr. Wayne Franklin, and I'm a cardiologist at Baylor College of Medicine in Houston. I'm also the founder and director of the Texas Adult Congenital Heart Disease Program at Texas Children's Hospital. This presentation is designed to help you recognize patients with adult congenital heart disease, and specifically those patients with systemic-to-pulmonary shunts in your clinical practice who may be at risk for developing or who may already have PAH. Often we think about congenital heart disease in terms of location and complexity, the size of the lesion, and the status of repair. The American College of Cardiology and the American Heart Association guidelines for the management of adults with congenital heart disease classify lesions according to their severity, from simple to moderate to complex. PAH is defined hemodynamically as a mean pulmonary arterial pressure greater than or equal to 25 millimeters of mercury, with a pulmonary capillary wedge pressure of less than or equal to 15 millimeters of mercury. The Fourth World Conference on Pulmonary Hypertension Classification offers another dimension to classifying PAH associated with ACHD by the type, size, and direction of a particular shunt, by the magnitude of change in pulmonary vascular resistance, and by a patient's clinical symptoms. In patients who've undergone shunt repair, categorization also includes the status of the repair. This classification system, published in 2008, describes 4 clinical settings in which PAH can be associated with ACHD. First, we need to consider PAH that is still present immediately after corrective surgery. PAH may also recur months or years after surgery in the absence of any significant postoperative lesions. Secondly, let's consider PAH with small ventricular septal defects, less than 1 centimeter, or atrial septal defects less than 2 centimeters in diameter on echocardiography. Also, consider PAH associated with congenital systemic-to-pulmonary shunts with moderate to large defects. This includes mild to moderate increases in pulmonary vascular resistance, or PVR, and the presence of a systemic-to-pulmonary shunt with no cyanosis at rest. Finally, Eisenmenger syndrome involves congenital systemic-to-pulmonary shunts resulting from large defects, with severe increases in PVR and a reversed, now pulmonary to systemic or bidirectional shunt. Also present are cyanosis, erythrocytosis, and multiple organ involvement. In this presentation, I will integrate these 2 classification systems by discussing the growing prevalence of adult congenital heart disease, including systemic-to-pulmonary shunts, the pathophysiology of PAH and congenital systemic-to-pulmonary shunts, and the factors that lead to its manifestation. I'll also discuss patient outcomes and advanced therapies for PAH associated with congenital systemic-to-pulmonary shunts, including Eisenmenger syndrome. But first, let's discuss why PAH in adult congenital heart disease, specifically systemic-to-pulmonary shunts, is of growing importance in the field of cardiology and why we need a call to action. So let's begin. We will now look at the need for greater awareness of the growing prevalence of ACHD. So, why do cardiologists increasingly need to be aware of PAH associated with ACHD? Well, really, for 2 reasons. The first and most important reason is that the number of individuals with congenital heart disease, or CHD, reaching adulthood is rapidly expanding. In the US, over the period from 1999 to 2006, mortality declined by 3.6% per year, for a decline in overall mortality of 24% in patients with CHD. Mortality decreased across all ages, which means that more children with CHD are surviving to adulthood, and more adults with CHD are living longer. You know, in the 1960s, before the development of cardiac surgery with cardiopulmonary bypass, about 50% of the children with congenital heart disease requiring therapy died within the first year of life, and less than 15% reached adulthood. But with advances in cardiac surgery and cardiology, an estimated 85% of babies born with complex congenital heart disease should now survive to adult life. It's estimated that within the next few years, 1 in 150 young adults will have some form of CHD. The second reason for increased awareness of PAH associated with ACHD is that many patients do not regularly see an ACHD specialist after their diagnosis. This figure shows attrition rates in patients who are diagnosed with CHD before the age of 6 and who survive to the age of 22. Between 18 and 22 years of age, only 39% of patients were still being seen in an outpatient cardiology clinic. This lack of continuity of care can delay diagnosis of cardiac complications, often making management more difficult. Follow-up care is dependent upon the severity of the PAH associated with the congenital heart defect, including systemic-to-pulmonary shunts. First, patients with simple defects can usually be adequately managed by the general medical community. However, these patients should visit an adult congenital heart disease center at least once so as to formulate a follow-up plan that addresses their future medical needs. Those with moderately complex defects should be seen periodically at an adult congenital heart disease center. Lastly, patients with highly complex defects should be seen regularly at such a center. Follow-up at these centers for moderately complex patients is recommended every 12 to 24 months, with highly complex patients requiring visits every 6 to 12 months. What is the prevalence of PAH among the estimated 1 million adults with CHD in the US today? Well, there are no hard data on this population, but we can gain insight from recent European studies. Data from the Concord Registry, a large Dutch registry of adults with congenital heart defects, show the prevalence of congenital heart disease, including PAH associated with systemic-to-pulmonary shunts. 40% of the overall Concord population were found to have defects that put them at high risk of developing PAH, including those individuals with congenital systemic-to-pulmonary shunts. 4% of the overall Concord ACHD population were diagnosed with PAH. And finally, 1% of the patients with ACHD may develop Eisenmenger syndrome. If we look further into specific defects, it has been reported that between 34 to 54% of individuals with an open ASD and between 28 to 47% with an open VSD developed PAH. In the next segment, I will discuss in more detail the pathogenesis of PAH and the specific defects that increase the risk of developing PAH associated with ACHD. Let's look more closely at the pathology of PAH in adult congenital heart disease, and we'll also look at idiopathic PAH or IPAH. Vascular injury and negative remodeling are the underlying causes of PAH in individuals with ACHD and those with IPAH, although the reasons for the injury differ. While the exact etiology of PAH is unknown, this vascular injury triggers a cascade of acute events, including inflammation and vasoconstriction. In turn, these acute events lead to vascular remodeling through hypertrophy, fibrosis, and cellular proliferation of both the endothelial and smooth muscle cells. This process shifts the pulmonary vascular bed from a low-resistance system to a high-resistance system. I mentioned earlier that although the cause of the injury is different for patients with PAH associated with ACHD, the resulting pathophysiology is similar. Before the development of recent therapeutic options, IPAH was rapidly progressive and led to right heart failure and death. In a moment, I will present results with these advanced therapies in patients with PAH associated with ACHD. But first, let's review the relationship of septal defects and vascular injury. In patients with septal defects, left-to-right shunting frequently produces pulmonary overcirculation due to increased blood flow to the lungs. This leads to the vascular injury that I mentioned before, caused by shear stress, which results in a chronic insult to the pulmonary vasculature. However, for defects in which the left-to-right shunt is mild and PVR is only mildly elevated, surgical repair can increase the chance of limiting or may even reverse PAH. Overall, an estimated 60% of ACHD patients have undergone at least one surgery prior to their adult years, and approximately half of these patients require reoperation during adulthood. Today, repair for congenital heart defects is usually offered as early as possible. When occurring in infancy, repair attempts to minimize the systemic and pulmonary complications associated with CHD. Now, as clinicians, we need to be aware that patients with ACHD may have existing vascular injury resulting from prolonged exposure, possibly from birth, to abnormal hemodynamic conditions such as high pulmonary arterial pressures. Let's dig a little deeper to see who among this adult population is at greatest risk for developing PAH. Earlier, we discussed that congenital systemic-to-pulmonary shunting is an important risk factor for development of PAH. With intracardiac shunts, it's basic plumbing. Blood flows to the areas of lower vascular resistance. Normally, pulmonary vascular resistance is lower than systemic vascular resistance, so in this setting, blood would flow left to right across the defect, leading to increased pulmonary blood flow as compared to systemic blood flow. However, when pulmonary vascular resistance exceeds systemic vascular resistance, the direction of the shunt reverses and becomes right to left. This may result in the condition that I referenced before, known as Eisenmenger syndrome. I will go into more detail about Eisenmenger physiology later in this discussion. Other factors that affect the development of PAH in patients with ACHD include the size and location of the defect, the type of shunt, and the timing of repair. An atrial septal defect, or ASD, one of the most common congenital heart defects, is associated with PAH. Occasionally, an ASD may not be diagnosed until adulthood. A retrospective analysis of data from the Ural Heart Survey showed that up to 1/3 of individuals with an unrepaired ASD will develop PAH. And even among those who did undergo repair, more than 1 in 10 develop PAH. Ventricular septal defects, or VSDs, are also a very common defect seen in patients with adult congenital heart disease. The Ural Heart Survey found that 28% of patients with unrepaired VSDs and 13% of patients with repaired VSDs develop PAH. This brings us to the topic of patient outcomes. Let's take a look at a large population-based study of adults with congenital heart disease from Montreal. This showed that nearly 6% of their study population had some form of pulmonary hypertension. These two Kaplan-Meier curves show survival over a 15-year follow-up period among adult CHD patients ages 18 to 39 years and ages 40 to 64 years with and without pulmonary hypertension. As you can see, survival is significantly worse among adult CHD patients with PH in contrast to those without PH. The Kaplan-Meier plots also show that the greatest impact of a PH diagnosis was on a younger age group relative to their counterparts without PH. Furthermore, there was an impact on mortality within the first few years after the diagnosis of PH in all age groups, as indicated by the early plot divergence. The bottom line is that all-cause mortality was more than 2-fold higher among adult CHD patients with pulmonary hypertension in comparison to those without pulmonary hypertension. If we take a look at CHD patients with Eisenmenger syndrome in particular, prognosis for this population is poor. In studies that assessed outcomes in patients with Eisenmenger syndrome prior to the development of modern PAH therapy, average life expectancy was less than 40 years. However, as demonstrated by the results of a recent study shown here, the use of advanced therapies for PAH was associated with improved survival in this patient population. This retrospective study analyzed data from 229 adult patients with Eisenmenger syndrome who were actively followed at a single center between 1999 and 2008. In fact, advanced therapies were associated with improved survival before and after adjusting for baseline clinical differences, as shown here in graphs A and B respectively. The greatest proportion had complex anatomy, and more than 50% were classified as New York Heart Association Class 3 or higher at baseline. 68 patients were either on advanced therapies at baseline or treatment was initiated during follow-up. Furthermore, of the 52 patients who died, only 2 were on advanced therapies. So what did these results mean for our patients with Eisenmenger syndrome and possibly other patients with congenital systemic-to-pulmonary shunts? As I mentioned earlier, the underlying cause of PAH in adult patients with congenital systemic-to-pulmonary shunts and vascular injury is the same as in IPAH, and in theory, treatment may also be similar. Idiopathic PAH responds to treatment with 3 different classes of drugs: endothelin receptor antagonists, known as ERAs, phosphodiesterase type 5 inhibitors, known as PDE5 inhibitors, and prostacyclin analogs. Outcomes with advanced PAH therapies in the most severely ill patients, such as those with Eisenmenger syndrome, suggest that the future for PAH associated with adult congenital systemic-to-pulmonary shunts may be promising. However, additional morbidity and mortality studies in adult populations with congenital systemic-to-pulmonary shunts need to be performed. I hope that you will regard the data presented today as a call to action. It is critical that cardiologists and other healthcare providers are aggressive in evaluating their patients with adult congenital heart disease, specifically systemic-to-pulmonary shunts, for possible PAH if these patients experience a change in functional status. Now, I realize that PAH and congenital systemic-to-pulmonary shunts can be difficult to identify because rather than new symptoms developing, existing symptoms can worsen. In Eisenmenger syndrome, this can lead to patients assuming their increased shortness of breath on exertion is just more of what they live with all their lives. Collaboration with a specialist in ACHD and systemic-to-pulmonary shunts, who is also an expert in PAH, may be appropriate. And remember, right heart catheterization remains the gold standard to confirm the diagnosis of PAH. While additional studies are needed, advanced therapies have been shown to improve survival in PAH associated with congenital systemic-to-pulmonary shunts and hold promise for these adult patients who develop PAH. I hope you found this presentation informative and that you'll share the importance of its content with your colleagues. Thank you.